International Day of Mental Health, we all did something for our mental health well-being. In addition to joining our webinar where we will talk partially about the access to mental health care, you also, I hope, have water with you, have comfortable seats and understand that that's a Friday and that's the end of the week, and you will have some rest and caring about yourself. And we are starting the webinar about the universal health coverage for people who use drugs in Europe, understanding European Union, but also broader Europe. And actually, this webinar is done within the Boost project, which is implemented with leadership of Correlation European Harm Reduction Network and in cooperation between four key community and harm reduction networks. We are doing it together as a Correlation European Harm Reduction Network, Eurasian Harm Reduction Association, European Network of People Who Use Drugs, EuroNPUD, and Drug Policy Network Southeast Europe, DPNSEE. And we are very happy that we are together advocating, developing resources, and ensuring access to HIV and hepatitis care and to healthcare broadly for people who use drugs in European region. And without further I believe that our speakers will speak much better and straight to the point about the problem. And I'm giving now a floor to Stella Bevel from WHO Regional Office for Europe with the key introductory view, what is happening and what is recommended by WHO Europe to ensure universal health coverage and access to health care for people who use drugs. Stella, the floor is yours.
Thank you, Lana, and good morning, and thank you very much to European Harm Reduction Association and its partners to organizing this important discussion. It's a pleasure to join, especially because of the World Mental Health Day, which reminds us that mental health is a universal human right. So today, integrated care for people who use drugs is the focus, and this goes to the core of WHO's vision that there is no health without mental health and no universal health coverage without inclusion of people who use drugs. Now, across the Europe and beyond, people who use drugs face multiple intersecting health challenges: substance use disorders, depression, anxiety, trauma, infectious diseases, and yet, as the recent public policy by networks highlights, I think I will choose with my connection. If that's okay, I will stop my camera. Okay. And let me know if I think it's a computer thing, not a connection thing, but I'll continue without camera. Thank you for understanding. So across Europe and beyond, people who use drugs face multiple intersecting challenges, and the policy brief that shows that this care is fragmented and exclusionary. Addiction treatment, mental health services, harm reduction operate in silos with separate funding, clinical pathways, and eligibility criteria. And this fragmentation leads to misdiagnosis, interrupted treatment, and preventable deaths. And it perpetuates stigma discrimination, which remains a major barrier to care. Put in the mix also the gender dimension, where women have a greater risk of depressive disorders and anxiety. PTSD symptoms are more common in women, and sex workers who use drugs are often more physically and sexually abused, or more likely to be second on the needle, injecting after male partners, and that adds to the mix of increased risks for mental health, but also communicable diseases. So from health-seeking behavior perspective, men have a much less drive to seek health services, not to mention mental health services. So there's also a gap on the behavior side. So from a WHO perspective, integration and person-centered care are the two buzzwords. And the mental health closely relates to physical health. Without mental health, there can be no true physical health. So, obviously, most of you are aware about the Mental Health Gap Action Program, MHGAP, which provides the framework for integrated mental, neurological, and substance use disorders into primary and community care. And some of the key recommendations on mental health in people who use drugs are psychosocial interventions for substance use disorders, and the MHGAP guideline emphasizes psychosocial interventions as a core component of treatment for substance abuse disorders. Also, cognitive behavior therapy, motivational interviewing, and contingency management. There's also a focus on digital health interventions with digitally delivered psychological and psychosocial interventions, as well as for alcohol use, anxiety, stress-related conditions, and self-harm, suicide prevention. Obviously, there are other dimensions: integrated care for comorbid conditions, support for carers, and human rights and equity, acceptability. There was also an update in 2023 for the MHGAP that underscored three directions critical for integration: integrated service delivery of addressing co-occurring mental health and substance use conditions together within the SAFE system, task sharing and workforce development, enabling the non-specialist health workers to provide effective evidence-based interventions, as well as human rights and recovery-oriented care, ensuring that treatment is voluntary, person-centered, and free from discrimination. There's also another document that you are also very much familiar. I will not go into the details of it, of a recommended package of interventions for HIV, hepatitis, STI prevention, and people who inject drugs. That does include mental health interventions as part of a comprehensive approach. And it focuses on integration of mental health services into harm reduction and HIV, hepatitis, STI care. The new thing that is a new recommendation from WHO is this year an update of the HIV clinical recommendations that recommends integration of HIV and mental health care. So mental health care for depression, anxiety, and alcohol use disorders should be integrated with HIV services. And this is a strong recommendation with moderate certainty of evidence for depression and low certainty evidence for anxiety and alcohol use disorder. But it's a premiere, I would say, that finally there's a position, evidence-based position of integrating mental health with HIV care. And obviously, this is a result of the outcome of a review of new evidence that has been documented since the last revision of our guidelines. In terms of lessons from the European region, at the regional level, it's not my team, it's another team that works with, there's a program on mental health, substance use and rehabilitation, and it promotes community-based integrated models of care. And the evidence generated shows that countries investing in combined approaches, linking opioid agonist therapy, psychosocial support, and mental health with primary care, achieve better outcomes in treatment, retention, recovery, and quality of life. However, the service gap remains wide, especially for people without insurance, migrants, women, and young people. And the possible barriers to the implementation of programs in the field of mental health are quite different, social and cultural barriers, obviously also stigma, but also low awareness of services and how to navigate the system, financial barriers, organizational and infrastructure barriers with lack of specialists and insufficient integration into the mainstream medicine, legal and political barriers, and psychological barriers. So closing this gap requires policy alignment, sustainable sustainable financing and meaningful engagement of communities and people with lived experience. Let me move to my last part of the introduction, Mental Health Day 2025. So each year, millions of people are affected by emergencies such as armed conflicts and natural disasters. These crises disrupt families, livelihoods, and essential services, and they profoundly impact mental health. This year's theme is access to services, mental health, and catastrophes and emergencies, both for people we serve and for our own workforce, which responds to multiple emergencies. I will use the example from Ukraine. So according to WHO research, the prevalence of mental health disorders among the population increases to 22% in times of war. This means that in Ukraine, every fifth citizen will either have or already has mental disorders. 13% will experience mild forms of depression, anxiety, and post-traumatic stress disorder, and 5% will be diagnosed with severe mental health illnesses such as psychotic disorders, severe forms of depression, anxiety disorders, or PTSD. And it's important that within this context, Ukraine took on a very high level leadership on developing a mental health strategy, actually at the level of First Lady. It's now an important public health intervention. And within that context, our team has focused on integrating mental health, opioid agonist maintenance treatment, and viral hepatitis services. So for that, we've conducted the training last year in September 2024, where we brought together actually primary healthcare and non-specialists together with mental health specialists and with OMT specialists and communicable disease specialists to really start discussing what it means to integrate mental health for these different categories in times of war. So I think there was quite a bit of focus on decentralization of both viral hepatitis service delivery, integration of mental health, OMT, and in the public health system. So it's just an example of the work, the type of work we do to walk the talk. And I think my last bit is a call to action to integrate care, to invest in people in partnerships and combat stigma. So we stand ready to continue working with government, civil society, community partners to make integrated, equitable, and compassionate care a reality for all people who use drugs. Thank you.
Thank you very much, Stella, and especially we hope that we all together we survive this tremendous UN crisis and funding crisis, and we all only facing what is happening with the healthcare because of the international support cut and health budget support cut. So I feel that we need to support each other even personally, and all my personal support goes to your team and to team of the health colleagues who are trying to coordinate all this work on the European level. Thank you very much for this intro, and I'm going to our marvelous Ligia Parodi from European Network of People Who Use Drugs to give her floor to represent the picture of the challenges and way out for community of people who use drugs. Ligia?
Thank you, Gana. Thank you for the opportunity to speak today, and I'm very honored to join this discussion on universal health coverage, not only as an advocate, but as a member of a network of people who use drugs, and then developing my role of demanding for our right to health, to dignity, and to justice. So I will start with some initial assertions. There is no universal health coverage if an entire population of people who use drugs remain systematically excluded. There is no universal health coverage without harm reduction, and without community-led services. Let's say that the problem is the systemic exclusion of people who use drugs. And despite commitments to universal health coverage across the EU and global frameworks like the Sustainable Development Goals, people who use drugs are routinely denied access to health systems every day, not by accident, but by design. Stigma, criminalization, and punitive drug policies create the barriers, the structural barriers that keep people who use drugs from receiving even basic care. Services are often fragmented, inaccessible, and unwelcoming, and in some cases, contact with healthcare leads directly to punishment, to surveillance, or forced treatment. And this is not a failure of those individuals, it is a policy failure. And exclusion is, of course, political. Universal health coverage is supposed to mean healthcare for all, but if we are honest, we are pushed out of the systems that claim to be universal, but in practice, they are very selective. We are excluded because of political choices rooted in stigma, in fear, and a long history of criminalization. We see this every day in our communities: preventable overdoses, untreated mental health crisis, rising infections, and deaths that never make the headlines because we are seen as disposable. So, universal health coverage may feel like an empty promise to people who use drugs. Despite barriers, our communities are not passive, and across Europe, there we have powerful examples of community-led and low-threshold and peer-driven initiatives that are making the difference. We lead change, and often with very few resources, but a deep knowledge and solidarity. I want to share some examples from European Network of People Who Use Drugs members, member organizations, and two of which were grantees within the Boost project. So the first one I want to talk about or to mention is Berlin in Germany. Berlin is a peer-led organization of people who use drugs, especially Ukrainian people, migrants in Germany, and they are fighting for the removal of barriers in the access to Hep C testing, treatment, and care of a significant community in Germany. The second example I want to bring is in Lithuania, Young Wave, a youth-led organization who is advocating for decriminalization as a way to promote socially just access to health services and harm reduction. Finally, I want to point in the direction of a very near example, which is CASO, the Portuguese Association of People Who Use Drugs, who has been a critical voice in pushing for integration of peers in each harm reduction service in Portugal. And MUSA is the mutual support group of women that is promoted by CASO in Porto. In 2022, a group of Portuguese women who use drugs, supported by Women Harm Reduction International, presented a shadow report to the Human Rights Commission for the elimination of all forms of discrimination against women, the UN office. It describes this piece of advocacy describes some of the problems and inequalities faced by women who use drugs in Portugal. And this includes information on institutionalized discrimination and violations of rights of women who use drugs every day in Portugal, including those associated with gender-based violence, access to health care, parental custody rights, and disproportionate judicial sentencing. Portugal, even with a history of 20 years of decriminalization, more than 20 years, Portugal lacks specific responses, including housing or other support for survivors. And women who use drugs are often excluded from domestic violence services and crisis shelter and housing. If these three examples, Musa, Berlin, and Young Wave, in more or less informal and modest or very modest funding ways, brought together people who use drugs to advocate for access to health and harm reduction, for universal health coverage, I want you to imagine what could be possible if those groups had real investment, real support, and a seat at the policy table to have a truly meaningful participation. These organizations are fighting for recognition, funding, and inclusion in decision-making. And this is what brings me to our bottom-up recommendations, and I will focus on 4 key asks. Universal health coverage must include harm reduction and mental care. They are essential, and excluding them means excluding people who use drugs from the services and the health. We also recommend the recognition of peer-led and low-threshold models as gateways to universal health coverage, like peer navigators, drop-in spaces, mobile outreach, and drug consumption rooms. They are cost-effective and proven entry points to care. We need funding for this, training, and formal recognition, and not only praise in reports, but actual and formal recognition. We also highlight that there is a need to sustainable financing for community-led services, social contracting, and direct EU funding and long-term investments should reach grassroots and peer-led groups and not only large NGOs or public institutions. So this is all to guarantee a meaningful participation of people who use drugs in the policy making of universal health coverage. People who use drugs should be put in national health boards, in EU consultations, in funding reviews, and not only included on a tokenistic or erratic consultation. We don't want to be only consulted. We want to co-create solutions. We need that EU leadership creates mechanisms for social contracting with peer-led groups to fund community-led monitoring, namely of universal health coverage, access, and quality. We encourage decriminalization and anti-stigma laws to support capacity building of drug user unions across member states. And we need to move from pilot projects to policy frameworks. It's not possible to remain with promising practices. We must go ahead and have some sustainable commitments too. This is not a question for charity. We offer proven, peer-led, cost-effective solutions that can make universal health coverage a reality for all. And all of us, communities, allies, and policymakers must keep building toward a system where healthcare truly leaves no one behind. Thank you.
Thank you very much, Lygia. And I want to echo what you're saying, that community-based services, community-led services, it's not luxury, it's not charity, it's essential services. And without them, there are no access to other closed room of the hospital. And when the doctors are sitting in the hospital and have the key to their room, they don't understand where is the barrier, why people are not coming to us. Thank you very much for your overview of community involvement in the accessing to universal health coverage. And now I will have maybe 5-7 minutes together with Igor to overview one more small overview specifically on mental health, and then we will go to the practical examples from different countries how you are solving these challenges. So now I will share the presentation just with the couple of pictures. Hopefully it will work. Could you see it now? Good. For us, I don't need to preach into the converted that for people who use drugs, for women who use drugs, majority of services is closed. Services and community support is closed because of drug use, because of criminalization, and because of a lack of the real linkage from community, from peer-led outreachers. And sometimes even harm reduction services, if they are not gender sensitive, they are also could not be this linking, but in majority cases we are. We had analysis, and I will show you later the publication, but the key challenges, they are not only about mental health, but basically it's coming from mental health systems. And we use the Eastern European examples of the more institutionalized and hospitalized mental health. But I could expect that not everywhere in European Union these challenges are already like overcame and solved all the problems of the lack of client-centered approach and lack of the very stigmatizing attitude, and in our case it's stigmatizing because of the reviews and because of the mental health challenges. And this double, maybe three, intersectionality will add something about the LGBT or sex work or poverty, and all together it's becoming throwing out the person from the care. But I need to highlight these challenges of hospitalizing and institutionalizing of the psychiatric care, in the same time having the problems with the lack of knowledge among psychiatrists about addiction. And for me, this picture, it's just the picture of the healthcare system, and there is the different hierarchies of like different systems of healthcare. And for sure, family doctors and the European health reforms trying to cope with this institutional boundaries or borders even between the institutions. But what we saw from at least 4 countries which were in our assessment, that there is the footballing of the patients, footballing of people when there is the addiction and mental health challenges or issues. Mental health doctor and system, even if person overcame all the barriers and went to the system and goes there, and even having paid something or somehow squeezed to the system, the mental health care system saying you need to be sober to come to us. First treat your addiction and then come to us. And the system of substance use healthcare or addiction treatment or narcology doctors, they are saying, okay, we will deal only with addiction, even being psychiatrists. And that's, we will hear from the country examples that it's not always the case. We are trying to overcome, not to footballing the patients. Sometimes there is the screening in the addiction centers, there is the screening in mental health diseases. Sometimes there could be real good integration, but that's not the systematic the real system, which is already working perfectly well. And in the same time, there is the social service and civil society structures and systems which need to be somehow integrated in all this picture. And it's already was mentioned about the mental health challenges, and I need to highlight the importance of understanding that that's challenges about the general population. And it's not only about Ukrainians. It is about everyone from us who are watching the news and who are experiencing more and more challenges. And sometimes the drones flying around the airport in Copenhagen could bring a lot of these challenges to the people, not only Ukrainian, but a lot of people. And we need to understand the levels that there is the general population, there is a lot of challenges among key populations, which are more stigmatized and lacking the access to support and sometimes family support, social support, and social care workers also experience additional burden, and sometimes they don't know how to cope with panic attack, how to cope with the gender-based violence caused by war, how to cope with their own state of mind and state of mental health. And then there are activists, and I see in our network the feeling of much more depressed feelings and feelings of hopelessness. And that's make us less effective and even less active as an activist. And I need to say that the mental health conditions and caring about ourselves, that's becoming crucial and key for us. And actually, that's the link to the research we did about the mental health challenges. Everything I mentioned already described there was the country examples from Czechia, Estonia, Moldova, and Poland. And I would be happy if you will see recommendations from the experts, because that was the real big work of a multi-dimensional team of researchers and activists together with the people who use drugs. And then we are coming into the broader context, and based on everything which our 4 networks, harm reduction and community networks in the region have done to monitor situation and to advocate, we together came to the joint advocacy initiative, which was supported by Boost project by European Commission. And that was for me personally, it was first time when 4 different networks developed joint advocacy strategy, and saying honestly, during the last year and a half, 2 years, we already very strongly pushing for all these issues all together. So it's not just a formal strategy. Yes, it's something common between us, but that's important prioritizing of our advocacy action in the crisis time when resources are drawing out, but we need to prioritize. And among these 4 priorities, you could see absolutely clearly that we are starting with the political will and to ensure financial sustainability for community-based and community-led harm reduction. And that's something which we are now doing all together as a campaigning to European Union, to to European Commission and Parliament to ensure this funding for health interventions and for harm reduction in the European drug strategy. And then the next priority is promoting community-driven harm reduction tailored to diverse needs of people who use drugs. And we understand that this communities, it's multiple intersecting communities. Priority 3, ensuring access to specific health services and meaning HIV response, opioid agonist treatment, and harm reduction. And fourth priority, actually, we are now doing this webinar sharing experience specifically on ensuring access to comprehensive care. And to present next two slides with our policy brief, and you could have a link and access to the policy brief, and we will share it in the chat. I will give a floor to Igor as a key pen authoring pen of this our policy brief.
Yeah, thank you. Thank you, Anya. So actually, I'm not gonna to steal not money, steal time from all of you. Not money, not time. So I will be very brief. So basically, to support this our joint advocacy strategy, we have developed 4 policy briefs where we collected everything evidence and policy recommendations. And so I suggest you to use this already developed policy brief. So with the referrals, it's good documents to support your advocacy or your issues you have in country or regional level. So and basically for all of this joint advocacy strategy, we have 4 policy briefs and to support each of these priority directions. And we have another policy briefs aiming this topic, universal health coverage for people who use drugs. So it's already our presenters today covered all the issues, and they are clear, and also recommendations provided by WHO, which is great. And so basically we, as a part of these policy briefs, we have clear recommendations to integrate harm reduction into UHC. And as we heard today, WHO also recommends integrate mental health with HIV services, which is also a great recommendation. And so we recommend expand one-stop and mobile services, which already proved their effectiveness and cost effectiveness. Allow community-based delivery, and so EuroNPUD also developed a policy brief, which is more in detail describe this issue with the recommendations. And so also we recommend institutionalized peer navigators, which is essential for ensuring UHC. And we also, there is special recommendations. We are recommending establish EU funding mechanism for inclusive healthcare. So it can be done within the existing EU for Health, or even to create a kind of special funding mechanism. But this is really essential, and especially now then then we are experiencing funding crisis and so on. So I stop here so you can have a link. Please use our develop policy briefs. We will be happy. Thank you, Ghana. You're muted.
Yes, I'm speaking while I'm muting. We are now have opportunity to learn how countries, different European countries, really trying to to do small steps, but trying to do this integration, whatever it could mean. And as Stella said, it could be one-stop shop, or it could be connecting and referrals. And what are the keys to do this? We will start with the Czechia, then we will have Lithuania and Romania. And I'm giving floor to Radek Jurnikl. I'm not sure that I could say it. So sorry, Radek. From Sananim, from Czech Republic, to share how the multidisciplinary harm reduction and low threshold opioid agonist treatment working there in Prague. Please, Radek.
Yeah, hello. You said almost perfectly right.
Sorry.
I hope that I screening my sharing my screen. Yeah, okay. So I'm gonna talk about the multidisciplinarity of our team as an outreach program in Senanin. We are the one of the biggest NGOs in Czech Republic who are focusing on helping people struggling with addiction, with focusing on non-alcoholic addictions. Uh, we, as an outreach program, we are working in Prague mainly, and as you can see, we already celebrated 30 years of our functioning. Uh, First, what I'm gonna talk about is that the multidisciplinarities that we have in our team. As you can see, that our team is completed by addictologists, nurse, social worker, native speaker, paramedic, and also we had well, trying to already head again the psychiatric inside of the team, and we also providing a P work. As you can see, we are trying to manage to do the catch all party, as you can say, when the client came and we find him in the streets, or we also providing our services via ambulance car, so that whenever the client need it, we can provide it inside our team. Like for I have a few examples in the slides. We also try to do something what we call networking with other services of Sananim, like for example, drop-in center. We are co-working a lot of them with them, or our specialized ambulances. Like for example, we have specialized ambulance for the parents of our clients, or people struggling with gambling addiction, or like specialized ambulance for young people and people who are released from hospital and so on. Also, we are inside the networking trying to have like really close contact with homeless shelters and low threshold accommodation for our clients and other outreach programs with or without focus on addictions. Like we are trying to be in contact with other outreach programs who are not providing like HR services and so on. And also, as you were talking about some help and support for people with hepatitis C treatment, we also linked medical faculty and facility to our like network, and we are able to provide and support people with hepatitis C treatment. I'm gonna talk about it later. So, what we are doing, like us, all the outreach programs and all addiction services, we are providing the basic HR access exchange material, like I was saying, with the streets or with the ambulance car. Also, the consultancy with the HR, drug abuse, social benefits, like navigating the social services and so on, and also like consulting the addiction treatment. As I was saying, when we get all those people inside our team, like the addictologists and social workers and so on, we can provide all the consultations in our team and not to do anything outside of. So we can develop some kind of uh, like bond with the client and provide the trust that we can do anything for him and what he needs or she or they or whatever. Uh, so he doesn't need to go to other facilities and like have sessions with well, another cowork or being posed in front of some barriers. As you were saying, well, when the hospitals is not providing basic healthcare, it's also happening in Czech Republic, and we are doing something for it. Also, as I was saying, we were the psychiatrists, so we were able to provide low threshold psychiatric approach and low threshold psychiatric care, not only with the focus on providing the opioid treatment, opioid substitution treatment, and the treatment of using methamphetamine with methylphenidate, but also with the basic mental health care, what all our clients needed. And also we get something we call hospital outreach, what I'm gonna talk right now. What we did is when there is some of our client who is hospitalized with something, it doesn't matter what is it, uh, after few days, maybe like 2 weeks, they're often like pushed out from the hospital. I just right now the word that they are released from the hospitals, uh, and they had nowhere to go. So we linked social worker inside the hospitals to our networking. And when the client is released from the hospital, they will like tell us, and we will provide with our linked shelters some basic accommodation. Also with our psychiatrist, or not only our psychiatrist inside the team, but also inside the synonym, uh, do some basic medications for his. Uh, for example, when the person who is addicted to opioids and was provided by substitution inside the hospital, and when he's released from the hospital, they will give him like 2 days medication and well do whatever you want. So we trying to do as fast as we can, take the anonymity data get the contact with our psychiatrist so he can prescribe the medication as he needed, and we can provide inside the emergency shelter where he's during his follow-up treatment until he's well done and can go up to the streets again or wherever he wants to go. And also, as we are trying to do this service, we just show the client that he can trust us, and they are going up to the another substitution treatment or inside the Suriname or inside other facilities in Prague. As I was saying, we also focusing on hepatitis C treatment. We do the classic seroprevalence testing from capillary blood. We know that you need to have the confirmation of the blood test, but our clients doesn't often go to the medical facility to do the confirmation. So we link the medical facility up to our team, and we are providing the full blood test once a week inside our ambulance, so we can provide the confirmation of the hepatitis C. Or also, if the person already had and cured the hep C, he needs to do the full blood test to, yes, I think you know, the full test because the surplus doesn't provide it, it will still be positive. So we linked the nurse up to our ambulance, and we can provide the full testing inside our ambulance. And if the clients came positive, we assist him to the specialized doctor who will prescribe the medication, and then we can provide the storing medication and keeping the dates of the test and keeping like using the medication and so on. Also the focusing on the EHRA so it doesn't get reinfected during the treatment. Like keeping the dates of the follow test and so on. We with this kind of treatment, this kind of program, we came so far that one of our nurses is like linked to the medical facility that she can do the blood test in the outreach and in another drop-in centers and another outreach programs in Prague. So that the Hep C treatment is so close to the clinic as it can be. And also we can provide the addiction treatment like as all the outreach programs can do. I think that was quick enough. So if you have any questions, I didn't talk about what we are doing, how many clients we get, and so on. So if you want to ask it, just ask.
I'm interested in treatment with methylphenidate, as I think it's something
Well,
quite.
yeah, we had a problem, like an integral problem. The main problem is using of methamphetamine, not so much on opioids and so on. So there was like one pilot program few years back that we can substitute the methamphetamine use with the methylphenidate. Because it's what most of our clients who use methylphenidate had an ADHD, so they're like self-medicating by themselves by the methamphetamine. Um, it came out the first study as it could help people who want to stop using the methamphetamine with the medication. So we try with our psychiatry to provide this to clients. Mostly we are using the retarded form of methylphenidate, so they doesn't need to use like 6 or 8 or 20 Ritalins a day, only like 2 Concerta or methylphenidate Sandoz. So they are taking less methamphetamine. The people who want to use less, it really helps them. When we can do the psychic and psychology test that they get the attention disorder and so on, we can ask the health the providers that we doesn't need to pay for full price for the pills. So it's even a little bit paid by the state, by the government. I hope I answer your question.
Yes, I have also two short questions. So first, so you mentioned that within your team you have one team member who is speaking mother languages or local languages. What are those languages? Most probably.
Yeah.
How many of those you have? And another question: who is funding all this beauty?
Okay, so the first one, the native speaker, we have a lot of clients from Eastern Europe. So our native speaker speaks Ukraine and Russian. And recently, we have a lot of people from Georgia, Moldova, and also, you'd say, from Ukraine. But we got a lot of Russian-speaking clients during our history. And our native speaker, she's with us for 22 years already. So that she can provide like the services in the native language or something that they can understand because, well, I'm young, so I doesn't understand Russian and so on so good. So it's better for it than to be so they can speak as they should. And the second one, who is paying for this? Like we get multifactional fundings. Most of it's from the government and from like health providing services and from the city. We also get some like extra money that doesn't belong to anything, and we can do that so we can buy the medication for clients. So as I was saying, talking about the medical outreach, in the first 2 weeks we can provide the OAT for client without him to pay for that medications. After that, it was paid from the insurance, but first 1 or 2 weeks we can provide him the medication as he needs. Because we in this kind of service we taking care mostly of people without the health insurance, like people from Slovakia or people from Ukraine without the asylum seeker coverage and so on. So this is like most the problem what we had and one why we developed this kind of service.
Super. Do you have, guys, participants, do you have any other questions and clarification to Radek? As for the substitution treatment for stimulant users, I know that this experience already Ukraine is trying to use this experience. We are waiting for results of their piloting of the same approach with the maybe larger scale, because there are several centers who are trying to pilot these interventions. Hopefully, we will have some more results and some broadening the understanding of substitution treatment, not away from the opioid substitution treatment. And that's actually the part of the discussion with the mental health doctors about medical treatment of PTSD and using the other substances to treat conditions. I don't see any hands. So maybe we will go to other speaker, and we are very grateful to you, Radek, but there could be more discussion at the end of the webinar. And we are going to Lithuania to get Gedrius from Republican Center for Addictive Disorders. Gedrius, the floor is yours. What are your challenges and what your solutions?
Thank you, Anna, for invitation to this webinar. So it's my pleasure to present Republican Center of Addictive Disorders of Vilnius. So this is a healthcare facility which includes inpatient and outpatient departments. So for the inpatient, we have abstinence treatment program and 2 rehabilitation programs. So we treat their different addictions. So the predominant is alcohol. Also, we have drug addiction, also the benzodiazepines, and all sorts of others as well. But those who are most popular. For the outpatient part, we have a possibility of the outpatient psychiatrist consultation, and we have also opioid substitution, opioid maintenance program with methadone and buprenorphine. So currently, just to give you a sense of the scope, we have around 280 methadone people on methadone and 50 on buprenorphine. So in total, around 330 individuals in both programs. We have our funding is a mixed funding, and which means that we have the budget line for the program, and this enables us to involve in the program immediately people who still don't have any insurance, but they have indications for the program. So that gives us a very quick acceptance to the program, and later on the person is going with help of the team to establish his insurance if he doesn't have one. If he has one, so he directly can go to the program with state insurance fund coverage. So basically, our program, methadone program, has a clear support payments guaranteed by state insurance fund, which gives us an opportunity for sustainable long-term funding. So this mixed opportunity allows us to involve a person without a delay. Where we get the patients. So basically, we work very closely with harm reduction networks, these organizations which are providing harm reduction services, and we do this in a quite close collaborative way. So basically, we have a social worker who also part-time works there, and in this way there is a very close linkage ensured. Also, we have, due to some legal barriers, low threshold centers, they cannot do testing because we still don't have community or lay providers testing possible. Therefore, we have a nurse who is working there as well. So basically, there is another aspect, the medical aspect as well there. So another one source of patients also mentioned in the previous presentation, this is the social centers and shelters where we also have a very close collaboration. So we have even our social workers do some kind of direct visits and basically also bring, let's say, assess and bring patients either to the program, maintenance program, or to addiction treatment. So basically, we offer the whole scope of possibilities based on the clinical indications. Our institution is a second level institution, so we also try to decentralize it to the primary health care, also mental health care services or family doctors. And currently in our capital in Vilnius, we have 120 individuals who are also taking methadone in clinics which are at primary level. And here we have certain challenges, certain problems, because we used to have quite good funding to arrange the methadone clinics in those areas, but of course there were a lot of hesitancy and stigma, we feel. And I think one of the main challenges which is faced by those primary level clinics is the funding mechanism. So basically, funding mechanism is not very attractive in order to get patients. So one of the examples I wanted to provide you is that we had a small city where there was a big problem of the drug addiction, and basically they have installed the ready site for methadone use for around 4 years, and they were not able to find a doctor and also the patients, they were not there. So basically we outsourced our doctor for a certain period of time, so almost for a half year. So he actually started the program, and actually it's now running really well. But the beginning was quite difficult because of the stigma of the attitude of the healthcare facility workers, and later actually there were quite some anecdotal evidence that this program has helped to solve some security problems. There were some positive reports from the police that there were less events and so on. So this actually helped, but it was in a way very, very random access. So these were examples of the decentralization challenges. In our institution, we have a team of the social workers who actually do case management, and basically the integration with other disease programs. That's how they are trying to incorporate patients. So we have indicator for HIV. So those individuals, they are tested regularly, and those who are positive, they are also assessed if they are taking ARVs. Recently, Hep C program has been also available, and this is additional, it's still not as indicator, but we feel this is an important part for individuals to motivate them to be in the program and so on. So I think a crucial role for success of the integration into other healthcare programs, this is social workers who do. And of course, they have the opportunity to get to a consultation of the psychiatrist. So in the program, we have built a system as we have so many patients. So basically, we do not reserve the time for psychiatrists, but we actually have psychiatrists' usual consultation time a bit longer. So just in case a methadone client needs a consultation, so he can squeeze in between any of other clients visiting the psychiatrist. So basically, we try to do flexible way to get the consultation. I think that's important. Otherwise, it's not working, the kind of fixed time next day in the future. So it should be done as soon as possible. So there is a big problem, alcohol use and also methadone. So we also provide treatment. It's possible to do to have the abstinence treatment, and also the places are limited. There are some issues, but we provide this option as well. So basically, there is a whole plethora of the possibilities for a person with additional disorders. So what we feel, what are the most challenges? So I think for decentralization of our services, it's the financial motivation. So the state insurance fund does not provide enough motivation for primary level to be interested into these services. And we find if that would be solved, so there are some advocacy and other measures. We think that we are taking care also of methodology, so then there would be only training possible, and then that system could really work quite well. Institutional boundaries also mentioned before, so social work and medical services are still finding the connection points and we see that our psychosocial support, we already connected very well in our institution, but at primary level, it depends. Some institutions, they already have social workers and they can do case management. Others may still need to get those workers. So basically, we feel that we still have some at the national level lack of people-centered care not only in this area but in many other medical areas. But we feel that good practice examples, partnerships, and advocacy efforts could really solve this, and properly installed mechanisms for the compensatory can put a sustainable way to give services and actually to help people. So that's in short. I think
Thank you.
Minutes, but I know that we.
Thank you very much, and I hear this about the seconding the doctor or narcology doctor to the small city. It could be a very interesting experience, as well as the social worker who are working from addiction center to the NGO. And my question is, I know that during the last couple of years there was the tremendous raise in the harm reduction funding from 35,000 euro per the whole country per year to 400,000 euro, which is really tremendous. How do you feel? Is it really support what you are doing in addiction center with the funding for harm reduction? Do you feel the difference? And do you feel that doctors and addiction center could be the advocate for continuous sustainable funding for harm reduction services?
So I think, yes, we feel there is a really tremendous change in the funding. So basically we have secured for 3 years, let's say more or less close to adequate funding, because we still, I think it's still, if you look at the commodities, so it's still a bit lower than UNAIDS WHO recommended, let's say needle syringes 200 per, we still a bit less than 100, but I think that this gives a bit of hope, because we have not only in 2 big cities, we have revived this activity in other cities. And another important thing is that the inbuilt activities could also include referrals. So basically this helps as a tool to get better interactions with those healthcare facilities. So harm reduction center, due to this funding, we have also included I think one of the criteria that we need to do referral and interactions and also data collection. So I think that is helping to reach common goal. What concerns further continuation of this activity, I think the very important thing is the studies. Actually, we don't have enough money to really to make IBBS, for example, and to show what are the changes in the risk behavior and what is the prevalence and so on. So this is a bit of challenge for us, but if we could do it, we would be able to show politicians the results, outcomes, and impact of this program, and then we could secure. But I think that's probably for us now currently challenged, but we already have a plan. I think we might do a study next year and provide results for the future funding.
Thank you, Igor.
Yes, I just wanted to also to mention, but this is also connected to research and so Gedrus, thank you for your intervention. And for me, it was very interesting that you mentioned that the expansion of the program impacted the reduction of crime in the neighborhood. I think it's also very important to document this evidence because it's also proof that the programs are effective not only in Lithuania but also in other countries, just to provide evidence for opposition and for those who say that programs are harmful and so on. Yeah, that just I wanted to say it's important to find money and to find possibilities to do this kind of operational researches and IBBS. This is very important to document our successes and effectiveness of the program. Thank you.
Thank you.
Thank you. It's very hard to transfer the anecdotal case when you are not mentioned in the city, and a police will never sign the report where it said that harm reduction and addiction treatment and mental health care reduce the level of crimes and could reduce their budgets for the drug policy. But decriminalization, it's something which we need to have in our mind and to use any opportunity to advocate for this. Thank you, Gedrius. And we are moving now to Romania, to Bucharest, to Monica Dan, to hear experience of community-based health services and integrated challenges done by ARAS. Please, Monica.
I will shortly talk about the services we provide and the advocacy activity we are doing, and about the always challenging political environment in which we operate, because this means a lot of effort from our part to stop the situation get worse than it is for people who use drugs from the legal point of view. I'm working with Romanian Association Against AIDS. HIV, hepatitis B, C, TB were important for our organization since its funding in 1992. Our harm reduction service started 25 years ago with outreach, then with a drop-in center, and then 18 years ago we started opioid substitution treatment, which is now the biggest program in Romania with the greatest number of clients, 650 places. Unfortunately, we do not succeed to ensure free of charge the treatment, but the outreach and the needle exchange is free of charge with a lot of effort from our part, especially to write project proposals, to gather funds for this. What I wanted to say is that we always in our organization, we tried to connect people to healthcare, especially in the infectious diseases, hospitals, mental health care, and also with care for I don't know how to say circulatory system for the wounds. This is a big challenge for our clients, especially if they don't have health insurance. Until this summer, it was a good thing that people who use drugs had several possibilities to get to have health insurance and have access to services as everybody who has health insurance has in Romania. We have in Romania what is called national health programs like HIV program, TB program, the mental health program, which provides methadone for certain service providers, and our organization is included because we have a partnership with the main infectious diseases hospital in Romania. It's their merit to have this opportunity for our clients since this year. Also, people in Romania could become insured if they have some kind of social situation. There is legislation which is in place to give this opportunity to have self-insurance on some very clear criteria. If a person has handicap disabilities, also registered with the social institutions. So our social workers were always, first of all, assessing this possibility of helping people to have health insurance. In order to have access to treatment for hepatitis C, for example, because they are not able to have treatment for hepatitis C unless they have health insurance or mental health treatment for other comorbidities. So we were very much focused on this health insurance issue, on raising funds to reduce and to include as many clients as possible in the programs where their price for the service for opiate substitution treatment is lower or free of charge. So this is a big effort done throughout the years. I'm sorry. And what I wanted to say is that we are struggling to maintain some funding from the public institutions. We are using all the possibilities existent in Romania for public funding, even it is very bureaucratic, even it is very small funding. We tried to force the Ministry of Health, which is supposed to provide funding for needles and syringes through the HIV program, national HIV program. We tried this several times, constantly during the years. We even had a lawsuit against the Ministry of Health, which we lost. Given the I don't know, bureaucracy again, how the way the law it was written, and we went to the European Court of to CEDO. So we did everything we could in order to secure the continuity and the access to our services. We did, and we do this constantly throughout the years. Our services are low threshold, so we are trying to involve our clients to train them as peer educators. There's still a lot of work to do, we know, because we are anyway an NGO, professional NGO. And what I wanted to say is that throughout the years we tried to, and mostly in the last 2 or 3 years, we tried to oppose in alliance with other actors, NGOs and other public actors in Romania, to oppose the growing, the oppressive legislation, which is which is rising from the parliament. Several members of the parliament have all the time, maybe tens of initiatives which are trying to increase the punishment for people who use drugs, for possession, for any kind of thing. So it is a constant effort to stop, to monitor and stop these initiatives. So we are trying to have alliance again in the NGO, in the civil society, and in the parliament. Still it is very difficult, and there are setbacks this year because the crisis, economic crisis Romania faces. This funding, the health insurance was cut for people who were in the HIV program, in the TB program, in all the programs, national health programs. So our clients, the majority, they lost their health insurance. So there are setbacks, always setbacks. And I will close my session, my speech with a question for you. I was, and we were at ARAS concerned with the European strategy, the next European strategy. We don't see how harm reduction is included there, how this strategy will impact the strategies in our countries, the way our politicians will shape the funding, the legislation. And so this is my question for you. How do you see this new European strategy in exactly this, the theme of the meeting today, universal access to healthcare and focus on peer interventions and community interventions. Thank you.
Thank you very much, Monica. And I need to reiterate this importance of civil society not only providing services, but also protecting this access to services. And this your way on going to the European Court on Human Rights and the going all the way, even legally, to protect access to services for the most marginalized group. That's very big part of the work, which usually is not included as a service provision. It's something else, and the cut of the funding for civil society and for community engagement, that's actually affects possibility of organization to protect rights more systematically. And thank you for this experience, and specifically mentioning this work of ARAS to protect society from more criminalization of the drug use and possession. And these attempts are going more and more all around the Europe, and Eastern Europe, unfortunately, is even more affected. I don't know if it's leftovers from totalitarian past or whatever, or just more populistic politicians here. I don't know. So you had a question about the strategy, and I'm as a chair of EU Civil Society Forum on Drugs. I need to say that we don't have certainty as for now. We, as a Civil Society Forum on Drugs, you see it that we are absolutely vocally in all the level, including the Euro Parliament specific groups, insisting that we do need key pillars on comprehensive health response to drug problems, and harm reduction as a specific pillar. As for now, yesterday there was the meeting with one of the meetings was European Commission, who is writing the strategy, and they again assured us that there will be specific pillar on health access, and even specific pillar on.
They don't provide access for the drafting the strategy, right?
No,
nobody see the draft, right?
Not yet.
Not
Not
yet.
yet, and what like they specifically arranged the meeting to show the key pillars and the structure, and that's good move from them. And I even received from the writer the letter saying yes, there are the key pillars in written. Maybe you have some comments. We will see. We still not losing the hope because the Danish presidency and Cyprus presidency ensuring us that they will put their effort in developing even operational plan, because European Commission don't want to have operational plan for the specific health issues, only for trafficking. So it's not solved yet. And in this crisis time, when all governments trying to cut harm reduction funding, cut health funding and social care specifically for criminalized and marginalized groups, European Commission need to protect, at least in the strategy, these approaches. And you are asking absolutely valid questions how countries will implement it, and do we have in European Union any measures, any tools to help countries or to force countries or to ensure that countries are implementing the balanced approach, especially if the health authorities in European level will not fund the specific actions, advocacy actions, and all of this. So challenges are on all the levels, and only what I feel that unless we are not losing each other and could support each other in our advocacy actions and in our provision of comprehensive services, we could be together, and this solidarity, that's what we have as for now. I don't know if it was answer. I don't have the good link to the strategy, which is absolutely comprehensive, but I could share what Jodie Cook shared with me as a formulation, suggested formulations, and it gives hope. So we now have some time I guess that I need to ask if anyone from the audience have something to say, something to add to what we have discussed, because I don't have
Magda.
Yes, Magda, please.
Yeah, thank you. Thank you for the presentations and for the webinar. I would have just short comments that came to my mind. First of all, we have to have in mind that drug use is very often self-medication for the pre-existing conditions and mental health. And when we are thinking about this way, remembering about that, then we see mental health and mental care in a slightly different perspective. The second thing, I'm thinking about the risk of medicalization, which can deprive people from self-determination and agency. So absolutely mental health is crucial, but over-medicalization is not the model that is very much the one we want. And regarding this medicalization, I do believe OAT should be regained by the community and should be owned more in the community and not the medical sector. And it comes with the experience of people in the treatment, how they are treated. And when we talk about trust between patients and doctors, these are very horrific conditions that when people are in treatment. Also, the abstinence-based model of OAT, which sounds itself a bit crazy, but this is the case in Poland very often, and the quality of OAT. So in psychiatry and access to psychiatrists and mental health in general is very difficult, but what is happening in OAT is exceptionally bad in terms of lack of trust and this punitive and very strict attitudes towards patients. And one more thing, mental. This is Ghana. What you mentioned. I want to highlight that the mental health of people working in harm reduction services, and we very often forget about it, not take it into account. But this is also essential, a very important issue for me. Thank you very much.
Thank you, Magda, and you highlighted all the challenges and additional need in our advocacy, and that's really we. It's hard to say. We are already 20 years advocating for comprehensive services, but it seems like we are starting from the couple of step back. Hopefully, we will have mental health capacities among us to advocate more. I don't see any hands. If so, maybe I will summarize a bit what was said in this discussion and in these examples. And I'm very grateful for colleagues from countries, doctors and civil society activists and community members who shared your experience. And here in this integrated care, the small step is a big victory. It's a big help. And even this connecting, and we've heard about the hospital outreach, which is very important when people are in different hospital, in different health facilities, and civil society have opportunity to bring them opioid agonist treatment, to connect them with the shelter, to meet them after hospital, to bring them to the shelter, and to care about the person in the circumstances they are. We heard about emergency shelters. Again, Prague is very gives us optimism that something is possible to connect all the services. But we also have heard about the social worker who from addiction center to the harm reduction services, supporting provision of services and supporting this friendly connections and immediate connections. Here is the psychiatrist in addiction center. Here is the narcology doctor in harm reduction facility. So you don't need to go somewhere. Here, that's the doctor, and he could prescribe the medication and help in navigating the system. We've heard about amazing experience of seconding or outsourcing the addiction treatment doctor to the general health care facilities to help them to provide addiction services and opioid agonist services, but in the same time to help them to understand addiction more and to integrate this support into the services. We've heard about the experience of providing services for those without documents, for those who migrants and need the services very much, even if the community service providers are volunteering or even need to protect the services through the court, through the justice system, to be sure that there are sources to provide low threshold services and integrated services based on community. And I hope that from the best you've heard even more good examples and some hints what could be done. But in general summary, I need to say that without decriminalization of drug use and possession, it's harder and harder to provide services, and harder to justify need in services and need of funding for comprehensive universal health access for people who use drugs. And that was important issue about gender sensitive services, community-led services, which are more effective and need to be effective. And that I like, Magda, your point about that opioid agonist treatment and health and services for people who use drugs should be regained by people, and that's really like this. We trust doctors, but the experience of peer-led or community-led support and case management, that's absolutely different experience. And for each of the subgroups, women, veterans of the war, migrants, undocumented migrants, Roma people, for each of this group, we definitely need to have the specific outreach peer workers, because that's different communities. And important point is absolutely important point for us. I need to highlight that to ensure advocacy and to ensure comprehensive responding to the needs of people, we need to have data. And countries usually forgetting or not budgeting the comprehensive behavioral surveillance surveys to understand what drugs are used, what are the barriers to health services, how to access, what is happening in the communities of people who use drugs. And thank you, Gedrius, for this issue about the IBBS and need to budget it regularly. So, and I guess that's actually key points which I took from the discussion, and I sincerely hope that this discussion will support you and you will feel solidarity with other countries within the Europe, and we all hope that the new strategy will bring us a bit more background for the for continuation of our work in advocacy and providing integrated health care for people who use drugs. Thank you very, very much for being with us.
Yeah, thank you, Anya, Ganna, for facilitating, for this great facilitation of this workshop. I think we done.
Yeah,
we
and
did it.
please take care. Please, even if it would be rainy day today, please take a walk. Have a good relaxing time without the screens. Take care about yourself, because the only resource we do have, it's us, and we need to be healthy and we need to be shining to support other people. We need to have energy to support other people, and our mental health, that's the key to survive. So take care, hugging you virtually, and have a good day.
Thank you.
Thank you. Bye.
Bye.
Thank you.